Do you guys see the sky on the other side? You see, you're on now, right?
I I can't understand you, Blah.
We are on right now. Do you, you're live stream right now?
I
I
still
can't.
can't understand.
I still can't understand you.
Sorry. All right, that better?
That maybe that's better. I think so.
Try it. Try
All
it.
right.
It's hard to tell.
Okay, yeah, we are live streaming. Welcome everyone to the podcast today. On the other line, I have Dr. Brian Hockel, very close to me in one of three, California, and Dr. Bill Haynes, the long-term experience orthodontist. The topic today we're talking about is airway state and how dentists, general dentists, or specialists, all specialists can get involved. So welcome to the podcast today, gentlemen.
We're happy to be here.
Thank you for having us. Really appreciate it.
I understand that, Dr. Heng, you've been doing dentistry 50 years. You have been doing orthodontist for many, many years, and there was some point of your life you switched gear from doing braces with extraction and you turned into doing them extraction. Could you tell us the story?
Right. I trained at the University of Minnesota starting in 1972 and finished my program and actually taught for a better part of a year before I then went into private practice. And I did exactly what I was taught to do. I removed teeth probably in more than half of my cases, and I retracted all the time. Uh, I I never even questioned it for several years. And then I began to look at the faces and didn't like what I saw. And there was a general dentist in the United States who was very critical of the orthodontic profession and teaching other general dentists to do orthodontics. And he was alleging that orthodontists were destroying faces, and that would be his words right there, and causing TMJ problems. I didn't like what I heard, but I began to think maybe he was right. And so in the early 1980s, I began to change. And for more than a decade, I was going to courses all of the time. And I stopped taking out teeth, which was a very challenging thing for me to do because I didn't know how to straighten teeth without doing it most of the time. And now that when I say that to orthodontists, they many times won't even want to talk to me. They'll view me as some kind of an untouchable because taking out teeth is part of what they were taught to do as well. But I've treated probably the most difficult cases that anyone ever treats, and I don't take out teeth. But along the way, what I realized was that faces fall back, and because of the way they fall back and why they fall back, because of poor rest oral posture, their airways get compromised. And I actually learned an approach starting actually 35 years ago this month, how to develop the face forward, developing the upper jaw forward and then the lower jaw forward. And when I saw, after doing that for more than a decade, I saw the airway improvements with it. I actually had a study done on patients I treated, and we found some rather dramatic improvements, 31% improvement at the dorsum of the palate, 23% at the angle of the mandible, and 9% down in the laryngopharyngeal area. This really got me interested in the airway. And that's the journey became less about the teeth and more about the airway. I also began reopening previous orthodontic extraction spaces for people starting in 1989. And that became a huge part of what I was doing. And I had people coming from all over the country and even some from outside the United States for that. And so I developed ways of not retracting. I've written articles about never retracting. And now we have our Echo mentorship where we try to train people to treat actually the way orthodontists were treating more than 100 years ago. Orthodontists were treating in the primary dentition in the early 1900s. And one of the reasons they were doing this was to correct mouth breathing and prevent mental retardation. Now that sounds pretty strange that someone more than 100 years ago be doing that. That's been in the literature for those who want to go find it. And that we actually present this material in part of our ECHO mentorship. So I'm semi-retired, but I'm still very much involved because I care a lot about the health of the kids that are growing up today.
Thank you so much, Dr. Brian Hockel. How did you get involved with Dr. Durham for the program and the training? And
How did you get involved with me, Brian?
Oh, well, it started with my dad's contact with Dr. Hang. He was at a meeting in London, England, and saw what people were doing with a type of treatment called orthotropics, which was a very difficult type of treatment to do. My dad had attempted to do it many years before, as had many of people in his circle of doctors. But when he went this time, Dr. Hang was there, and he came back from this meeting and told me there's an American orthodontist who is applying these teachings of using oral posture to help correct facial growth, but he's doing it in a more systematic way and is somewhat adapted to the American orthodontic standards of technology. So I said, well, let's bring him to our study club. And in 2004, he came to our study club here at the office. And after hearing him, it really changed a lot of the way I was thinking and the way I was practicing. And I won't say it was in a pleasurable way. I knew he was speaking the truth, but it was a very difficult truth to hear, because what it meant was that my way of practicing up until then was doing things that maybe weren't right. So there were a lot of things I was doing that were right. My dad and the people like him were teaching non-extraction techniques, trying to avoid surgery wherever possible, as least invasive as possible. But there were things that we were doing that were retractive. When you pull teeth backward in the face, it gives the tongue less room and it can force the lower jaw backward. And even though we might think that we're using appliances that are bringing the lower jaw forward, a lot of the time, the force systems that those appliances set up are actually no different from a headgear, which means very retractive, pulling backward, especially on the upper arch. So I had to kind of rethink everything. This is in 2004, 2005, and I joined Dr. Hang's mentorship, which he's still teaching even now in his ECHO mentorship to learn how to treat growing kids. And as I said, it kind of made a huge readjustment in everything that I was doing. And I haven't looked back since. It's been a great way to sojourn into the whole airway world. I think people don't realize how airway and orthodontics didn't really intersect until Dr. Hang came along. He's really the first one to have looked at what was happening with traditional ways of treating in orthodontics and the airway. And not only how it was getting worse with traditional ways, but how he could change what he was doing so that it would improve the airway. And as you said, a study was done using his patients that showed this, but it's kind of a common thing that those of us find who have followed his techniques, that things improve if we do things the right way.
it's beautiful, because what happened is when I first interviewed Dr. maybe like 6 years, 4 years ago, one of his patients were looking for me because I'm very close to her house. And she said, you interviewed Dr. Durham. That's the reason why I come to you. I said, okay, tell me what you have. So she told me that she traveled from Northern California all the way to Southern California for Dr. Hang to open up the theater premolar that
Yes.
extracted, and have two implants, her face is better, and
Yeah.
ever since she had no more headache, no more headache.
That's part of in our ERRS mentorship. That's what we do. That's for people age 10 and older. Our ECHO is for people age 10 and under. We focus on really treating the primary dentition for that group. And I'd love to see orthodontics completed before the first permanent tooth erupts. That's the goal of that mentorship. But for reopening extraction spaces, we have a separate mentorship, ERRS, as in mistake. That's an acronym. extraction, retraction, regret syndrome. And it's a very real syndrome. It's not a joke. It's real. And we define it as a constellation of aesthetic, functional, and emotional signs and symptoms brought on by orthodontic retraction, all of which are preventable because actually retraction is preventable. The sad part is much of traditional orthodontics is retractive, whether you take out teeth, whether you use a headgear, whether you use a so-called functional appliance, which has a headgear effect, or even just closing spaces where there's generalized spacing, class 2 elastics, these are all retractive, and we don't want to see that. And these are the most complex cases because the triad of aesthetic, functional, and emotional makes a very complex patient. What happens is, someone gets the treatment done and they don't like their face. Their lips are back, their arch is narrower, their cheeks are flat, their upper and lower jaws are back. They don't like that. And they're very perceptive and they seek solutions for that. The functional issues are, the headaches often because the mandible gets trapped, the front teeth hit too soon, shoves the jaw back, and we have problems here. If that goes on for long enough, then the emotional part really kicks in, particularly when they've traveled from state to state and sometimes spent hundreds of thousands of dollars seeking a solution. But that's the hardest part, is to deal with all three of those things, the aesthetic, the functional, and the emotional, which makes it a real challenge. Some of the times with those patients, we can merely reopen spaces for them and they're okay. Other times we need to have orthognathic surgery because both the jaws are so far back, there's no way that we're going to open the airway up and help somebody to be able to breathe well. But there's a huge demand for this kind of thing. I get contacted all the time for people from all over the world. From Asia, from Europe, from Africa, from South America, from Australia, New Zealand. I've had people contact me from all over. It's a big deal. So
we're also very fortunate, Locke. I don't know if you knew this, but there's a world-class oral surgeon who is in St. Louis, Missouri, who has opened an office recently in Walnut Creek. I say recently, but over a year ago. And he's been able to help me with my patients. And when jaw surgery is required, he's just been able to do the most amazing types of treatment for these patients. And so I think having that as a possibility for some patients has been we're fortunate to have him here in our area.
He's really excellent. I have a huge background in orthodontic surgery, having done hundreds of cases in my career. And actually, when I was in my residency, I went into the operating room to assist the surgeons on 10 of my own surgical cases back in the 1970s. So I followed that, and I know who the really major players are, and you're incredibly lucky to have him right in Walnut Creek. And Brian knows as much about this as anybody could possibly know because he's had it done himself. Not because he was retracted, but what was it, 2 years ago now, coming up on 2 years, Brian had orthognathic surgery for his own sleep apnea. And for the first time in, I guess, decades, Brian, you can now sleep on your back, and he's getting a good night's sleep. And he can tell you the benefits of good sleep versus poor sleep and the medical ramifications. We see people all the time who have high blood pressure meds, and once they start breathing and sleeping properly, their blood pressure may plummet to a normal level within days post-surgery, and I have examples of that. So all of this is very comprehensive. In the ERRS mentorship, people need to have a pretty good background in orthodontics to be part of that, because we're doing some very complex things, differentiating from, could you then open up some extraction spaces for somebody and have them be okay? Or are they a surgical candidate? And you want to know that before you start to do anything, because reopening spaces, if you fall short, you may have to close the spaces if you're going to do surgery. And there's reasons that we have that conversation. So Brian's been very good at this, and he's treating the most complex cases there are out there, reopening spaces, preparing patients for surgery. And if you want to get involved with this, you have this great resource with a surgeon who's literally world class and coming up with new things all the time. I'm very impressed by him.
I'd be very happy to make the introduction for you, and really I'm happy to work with you on any cases as well and help guide you through it. You could get no better mentor than Dr. Hang for this kind of thing. He meets with a group of us once a month by Zoom, and then we meet in person twice a year to discuss cases, to work with experts around the country, and it's just been invaluable to be able to do that. He mentioned my surgery. So there's me 1 day before and 3 weeks after doing double jaw surgery in St. Louis with the surgeon we're talking about. And it allowed my airway to go from 22 square millimeters up to 266. It was a 12 times increase in the airway. And I knew what I was getting into because I had treated so many other patients with the same surgeon. And it wasn't I was trying something out. I knew that there was a good chance this was going to be a big help for me. So I was a bit biased in going into it, and I have no doubts at all, no regrets in having done it myself.
Yeah.
So, especially for somebody like a diabetes, is this really risky?
I couldn't understand you, Locke.
I think jaw surgery for somebody around 60 or older, is this very risky? Is it very tough to recover?
You can do this at any age. I won't tell you Brian's age, but he's over 50. The oldest person I ever did it on was 3 weeks short of 75. And this gentleman, I'm not joking, and within 5 weeks, he was out riding his bike. After the surgery, he was out riding his bike 20 miles or more. The year before he had the surgery, he had ridden his bike from Jacksonville, Florida to San Clemente, California with a group of bicycle friends. And so he was a very fit guy, but he had sleep apnea, and he came through the surgery remarkably well. 3 weeks short of 75, he did the surgery. Now,
I've had patients do it when they were teenagers, and I was 61 when I did the surgery. And I wish I could turn back the clock and do it when I was in my 20s or 30s. But frankly, the technology and the techniques hadn't developed at that time. So it wasn't really an option. We can do things now that even 5 and 10 years ago, we couldn't do. Really, new avenues have opened up, thanks in large part to the creativity and innovation abilities of the surgeon that we work with.
Right.
Who's that surgeon?
Who's the surgeon? Dr. Reza Movahed, Movahed. As I said, he's based in St. Louis, but he has an office here on Ignacio Valley Road in Walnut Creek.
So I just want to go back, so when you are the second generation dentist, your father is an orthodontist, and you're into a general dentist, but you specialize in basic areas?
I couldn't understand entirely.
Your father was, I thought your father was an orthodontist. Brian's father is a general dentist who also did orthodontics way back then. He was way ahead of his time and very innovative person. And that's where Brian, had him as a role model. And so he paved the road for Brian, and Brian has gone way past where his dad was, obviously. But his dad opened the door for him to understand that he could be doing this. I think your listeners...
Called it...
Go ahead, Brian.
He called it the Hockel School of Orthodontics. And we had a study club that met here in the office regularly, and he was really my first and main mentor, as he has been for many people over the years. Along with a group called the AAGO, there was a series of courses that the Academy of Airway and Nathologic Orthopedics, the AAGO, they were being taught in the late 70s, 80s, as well as being taught today, and actually help with the teaching of these courses. But that was where I began. But really, these mentorships that Bill Hang teaches are state of the art and the best education not only because of the content and the philosophy and what one is able to do treatment-wise for patients, having learned these techniques and approaches, but also because of the support that they'll receive from Dr. Hang. There's an app that Dr. Hang uses onto which you can post a case, and he gives immediate, comprehensive, detailed feedback for these cases, so you don't feel like you're going to be high and dry once you start a case. If a question comes up, you're going to be able to get the question answered through the app that communicates with Dr. Hang and the other members of these groups. There's one for the ECHO mentorship and one for the ERRS mentorship. And frankly, as a beginner, for me, that was essential. I needed to have a safety net so I could get my questions answered right away. And at first, that was my dad for many years. And then over the past many years, having that opportunity with Dr. Hang has left it, you feel more confident in taking on a case that you might have otherwise been too intimidated to approach.
The new dentist who just graduated from dentistry, could you share your mentorship program, or you need to wait a few years later?
I can't understand you, Law.
I couldn't understand either.
No.
Do you think that for new graduate dentists, could he or she share the mentorship program, or wait until they practice for a while?
I think you're asking me who can be in it. I'm not sure. I'm not hearing you well. It's for general dentists who do orthodontics, pediatric dentists, orthodontists who want to be involved, and the mentorship really it starts out with a 3-day session to begin with in person. Then we have monthly webinars, an hour and a half long, where people present cases. And as Brian said, we have our online forum where you present your cases before you start them. I don't want anyone to start cases without me seeing them first. And then I want people to present them along the way so that I can see their progress. And it's a very non-threatening forum. If anyone on it would ever criticize another person, they would never post again on the internet. Fortunately, we've not had these kinds of things happen. But we want it to be a very comfortable, safe place for people. And as Brian says, I respond usually within a few minutes or a few hours. Even if I'm traveling, I won't go to bed unless I have responded to all the posts that have been out there. People take courses all the time on Airway, and the sad part is many times they feel left high and dry with no support, nobody there to help them. And lots of times they don't have a concrete, they're not even clear on the diagnosis and the treatment planning. We want you to understand what you're doing, why you're doing it. It's not a cookbook approach. I want to teach you how to think and treatment plan on your own. But I'm there to help if you have problems along the way and you gain your confidence. And the other really big issue here that I think you have to understand, there's a lot of interest in Airway now. It's kind of the cool thing to do. And the trouble is the knee-jerk reaction to it always is expand, 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 expand. And all that is lateral expansion. But the real problem is that our faces are not as far forward as our ancestors. And so you have to understand that the more you can do to develop the face forward, the more successful you're going to be. Nobody but we're the ones that are teaching that because we have the expertise in that. And it's terribly important to get the best results that you are able to develop the face forward, which is very challenging to do, as Brian and I both said, but it's critical to success. Now, I'm not going to brag and say that every case I'm going to treat or you're going to treat is going to turn out successfully. That's not the case, and anyone who tells you that, well, excuse me, you need to be skeptical like I am. But the fact is, there are lots of predictable things that you can do that have a great chance of success, but it isn't just throwing in a preformed appliance and hope for the best. It's not just expand, expand, and expand some more and hope for the best. No, it's much, much more than that. And I want to make a big point why I think this is the best time to practice dentistry in the history of dentistry. I happen to believe that dentistry is the center of healthcare. By what we do with developing the face forward and the airway, that determines everything that goes on. All the chronic diseases known to man, heart attack, stroke, cancer, diabetes problems, all these major issues are associated with poor sleep. ADHD associated with sleep. All these issues are associated with this. And whether you like it or not, we now have a movement in our country to be healthier. I'm not going to get political about this, but there's a nationwide understanding that we need to get healthier. And we're dealing with a lifestyle issue here. James Nestor wrote a book called Breath, was published in 2020. It was number 6 on the New York Times bestseller list, published in 37 languages. And it made the mothers of the world understand this. They understand about airway, and there it is, right there, Breath. If you haven't read it, you need to read it. The fact is, mothers know about this, and in the last few years of my practice, they were coming very well educated. The demand is far greater than the ability of anyone to treat these cases. There are lots of people saying they're treating it, but many of them are doing things which I happen to believe aren't going to be that helpful. We have innovative ways of treating class 2 patients and camouflaging the case and not doing surgery to advance the jaws forward. But the focus of everything we do is to never, ever, ever retract even minutely. So there are lots of specifics to it. Brian's very good at it. He understands all this stuff, and he's getting amazing results. He's doing some other things that I wasn't even doing. So with what we put together, I think we have a great program here, and the fact is, the incidence of airway problems, virtually every family has someone in the family who has airway problem when you know the right questions to ask. And many of the people, if not most of the people who take my echo course, are people who have young kids, and they're very concerned about their own kids. I did an interview just yesterday with a woman who is from another state. She wants to take my course, and she's going to take it. And she's done the class. She's a pediatric dentist, and she's got a 5 and a 7-year-old kid. She's taken to the orthodontist, and the orthodontist is saying, "Well, wait and wait and wait and wait and wait." Well, when you smell smoke, you don't wait to call the fire department. And so many kids today have problems that, if you know the right questions, they are serious problems. They're serious health problems, and left untreated, they can have brain damage with even one night of reduced oxygen saturation. We'll get you the references out of the refereed literature to support that statement. So everybody has, and by the way, this same woman talked to me about her husband and how he snores and how he has problems this way. It's rampant. It's the way it is. And it couldn't be a better time. In 2017, the ADA mandated that all dentists screen for airway problems in September of 2017. And how many dentists today are doing that? Not that many. But the demand is there, believe me. Brian gets patients from all over. Have you started to count the number of states you have them coming from, Brian?
From several out of states, from the UK, from China. Yeah, there's a need for it in so many places of the world, and there just isn't really the ability to fill the demand. Someone wrote recently from Cambodia, and I was able to refer him to someone we know in that general area, but that's rare.
Yeah, we have someone who was in our ERRS mentorship who's in Cambodia, but most of the time I don't have someone I can refer to. That's why I referred many to Brian, people from China, and there's plenty of people in China that are having these problems because they are getting retracted like crazy. I can tell you why, but it's way beyond this conversation.
Yeah, and in our area, Locke, I mean, even people who say that they're doing orthodontics in a way that's sensitive to the airway, they're 100% of the time, 100% of the time, they are tending to pull teeth backward in order to fix the bite, because the way the teeth fit together is the most important thing to them. They're not really looking at how it affects the face or how it affects the airway. So it's an uncomfortable position sometimes, because you're having to call into question what the specialists around us are doing. but they're not unanimous in this. There are many orthodontic specialists who understand the significance of the airway. They're just in the minority right now, and hopefully that's going to change in time. But for a lot of our patients who have problems, we can't wait for that change globally. We've got to just do what we can do to help our patients, both with the airway, with the aesthetics, the function. And it's a fantastic time to be able to do this to help people because there's such a need.
Yep.
Very powerful. Can you give a normal graph of a few questions that are quick related to, okay, you think now we have airway state, can you give the audience a couple of questions that
I can't understand you, Locke.
I wonder if you can have a few common questions that you approach the parent to ask whether there might be a child with airway problem, thing like that.
I'm having a hard time too. You know what you could do, Locke? You can edit this out, but write it in the notes. If you write the question in the notes, then we could answer it and you could just edit out this part of it.
Right.
You can give, if people want to contact us, you have my contact information. They can email me with questions. If they want to, I'm happy to Zoom with somebody if they're interested to know more about either one of these mentorships. Feel free to contact me through that, through my contact information on Ortho to Health. And I'm happy to have someone set up a Zoom where I can answer their questions and see if indeed what we do might be helpful to them. And I also like to see, I don't want to have people in my group for the wrong reasons. I like to know them before they come. It's not that I get an ego thing about giving courses. That's not it at all. I do it because I want to do it, because I want them to be able to do what I was doing and help people. And I want to know that they're the right character to do that. And I want to be able to see their case. I want to be able to train them. I want to be able to see their cases, and I want to be able to use them as a resource. And when people contact me and say, gee, I live in East Pitchfork, Nebraska. Do you have someone who can help me? And I'll say, oh my gosh, yes, I do. Please see blah, 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 because I can comfortably refer to that person because I've seen that person's cases and I know they know what to do. It's not just that they've taken my course. I have to see that they know what to do, which is why I comfortably refer to Brian all the time.
Same here. I'm happy to answer questions both from patients or from doctors who want to go on this journey and learn how to start. I've seen many of them do it over the years, many with no orthodontic experience at all. And we're able to take them from zero knowledge to being able to do some tremendous things. Sometimes just for kids. Sometimes they just want to stick with the younger age group. But for many of the doctors who've gone through this educational process, I've seen them able to help adults in some of the most complex things that really have baffled other airway professional, so-called airway orthodontists or practitioners, as well as the specialists in the profession. So it's possible to do. And certainly if somebody like you who has orthodontic experience, it's an amazing fit. It would be good to take whatever skills have been built up until now and take them to the next level. There are a lot of possibilities there. But yeah, my email is brian@hockel.com, Hockel. People are more than welcome to reach out, and I'm happy to help any way I can.
I have another dentist, a general dentist in a major city in the United States, who we trained starting more than a decade ago. And his dad was a dentist as well, but he no longer does any general dentistry. All he does is orthodontics, and he treats in the primary dentition with the echo program that we do. He treats those kinds of cases too, and the most complex cases involving reopening spaces and surgery. So he has hired somebody else to do all the general dentistry in his practice. I also have a number of pediatric dentists who no longer do any restorative dentistry at all. All they do is airway, and they're very good at it. They are very happy doing it. They feel very well rewarded at it. And oh, by the way, yes, it is possible to make a living doing this. And it's fun when you have people who literally thank you in those words for saving their life. And I have letters from people, emails from people that say those very words. Thank you for saving my life. So it's a lot of fun. I hope this is helpful to your listeners. And again, Brian and I are both happy to talk with anybody here who's interested. Okay.
Thank you very much. Gentlemen, I'm sorry for the technical difficulties, but I hope to bring you guys back next time. Hopefully, we have a little bit better technology and technical interview installed. But thank you for coming to the
Okay.
today. Introduce yourself. Thank you. Have a good day.
Okay.
Thank you very much.
Thank you
Appreciate
very
your
much,
time.
Locke.
Thank
You have a good weekend. Bye now.
Take care.
Thanks, Brian.